Welcome everyone to today's webinar, Healthcare 2021, the year of Tele-everything. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. And if at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. Thank you so much for being here today, and I'm going to turn the floor over to Dr. Hallberg, who will start today's presentation.
Hi, I'm Dr. Sarah Hallberg, Medical Director here at Virta, and I'll be your moderator today. For the health plan leaders, employer benefit leaders, and health systems leaders in the room, we have an exciting lineup for you. COVID-19 spurred a wave of telemedicine adoption, but just how much is just hype and how much will truly deliver sustained transformation to healthcare? What changes will actually endure after the dust from the pandemic settles? We will be exploring these questions through a high-level strategic discussion with our panelists, Dr. Bob Kocher, Dr. Rahul Rajkumar, and Dr. Robert Ratner. Together, we'll discuss trends in health IT investment in Silicon Valley and how to stay ahead of them, health policy implications of President Joe Biden and Democratic control, reimagining value-based care strategy in a virtual world, and changing the diabetes care paradigm from management to reversal. With that, let me introduce our first panelist, Dr. Bob Kocher. Bob is a partner at the venture capital firm Venrock and serves on the state of California's COVID-19 response team. Prior to Venrock, Bob served in the Obama administration as Special Assistant to the President for Healthcare and Economic Policy on the National Economic Council, and, among other things, was a key architect behind the Affordable Care Act. Before that, he also worked at the McKinsey & Company. With that, I'll hand it over to you, Dr. Kocher. We are delighted to have you.
Thank you, Sarah. It's really nice to be here, and thank you to all of you who are virtually joining us today. I'm going to share some vantage points from Silicon Valley about how COVID-19 has led to a bunch of innovations and I think thoughtfulness around ways to incorporate telemedicine and virtual care into care, and also speak to more generally some of the trends that are influencing what's being done. One of the most extraordinary things that's happened over the last year is that capital has flowed into healthcare in sort of unprecedented ways. As the world grappled with the pandemic, people realized that we will need a better healthcare system both in America and globally, and that healthcare system is probably much more hybrid, not so dependent on being in person, but one that combines virtual care, texting, email, continuous monitoring of patients, as well as a lot more feedback from patients and patient-reported outcomes. This graph here shows you sort of the rate at which capital has flowed in, and we've seen companies with traction really raise a lot of money, which will give them more time to build their futures and to become hopefully important companies. As I step back, this webinar is well titled, Tele-everything. That's exactly right. With COVID-19, we went through almost a decade worth of adoption of telemedicine in a few months when the conventional healthcare system basically shut down and patients were, both wanted to and forced to get their care virtually, and providers also all had to learn how to do it. And so that led to lots of practice and lots of learning and actually quite a bit of satisfaction. People liked it, quality ended up being okay, and we also learned that, various populations that people weren't sure about, adopted them and actually quite well, both older people and more vulnerable populations, which gave us a lot of confidence that there's ways to continue using telemedicine. The public markets responded. If you were a public company doing virtual care, your stock's up a bunch. And if you were a company in the private markets, you probably raised a bunch of capital. We saw really positive signs around how virtual care can improve things like mental health care, an area where need has certainly expanded a great deal this year, and where we undertreat people, paradoxically. Diabetes, which we'll hear more about, musculoskeletal conditions, and also, generally speaking, specialty care. Prior to COVID, most telemedicine was primary care, pediatric care, and things at night where you weren't sure what to do. And now you can get all forms of specialty care consults done virtually. The incumbent players, have really incorporated telemedicine. I am affiliated with Stanford, and at Stanford, we have a goal of actually having more than half of our visits going forward being virtual, which is a giant change from how we've been thinking before. This curve just shows you the setting adoption. You can see the in-person visits dropped a ton, and they were replaced by virtual care. And today we're at a new baseline, much higher than before for telemedicine, which is kind of, I term it click and mortar, where patients will initiate care often in person and then have a great deal of that care done virtually afterwards. And there's some really great benefits of that. One is you can check on people quickly every day. You don't have to wait for them to come back and see you. You can adjust medicines more quickly. You can respond to changes more quickly. And so I think that this new hybrid model will be very, very good for patients. This just shows you the dramatic increase in funding. Funding's, tripled last year in this area. And that's in part because Medicare for the first time is reimbursing telemedicine. And for COVID, allowed people to practice across state lines. So it's been much more simple to scale up some of these companies. I hope that will continue. And I think the Biden administration is looking carefully at how to continue the good parts of telemedicine such that it can be incorporated. On value-based care, this is when doctors entered into new payment models that rewards them for more cost-effective care. You're seeing that those providers in particular have found that virtual care works quite well. Having ways to, at low cost, check on people and help avoid hospitalizations and hospital costs. They're finding that actually combining specialty care, primary care can work very, very well. And another really promising sign is that when you're managing population cost, you begin to think much more about the things that impact their health, so social determinants of health. And companies like UnitedHealth and Now Power, two examples which have grown a lot this year, to think about ways to make sure people are getting the social services they need to actually stay healthy and be able to be compliant with the cares, with the medical care that could help them with their conditions. An area that's very important is risk-based primary care to have this all work. They tend to be the people that are most interested in the virtual combinations. And what we're seeing is that those businesses have grown nicely during the pandemic. Oak Street Health is a company that went public. They do a great job at Medicare Advantage primary care. And there's a cohort of others, Aledade, Iora, Chin, Village, CityBlock, who also do extraordinary primary care. Notably, CityBlock takes care of Medicaid patients, and that's a population that we've seen a lot during the pandemic is underserved. And so it's wonderful to see investment and innovation going into that sector too. I hope that virtual care is a way that we can really improve access for populations that are less well served and make big improvements in health outcome disparities. The rate limiting step is going to be the hospitals. Hospitals are the ones that have both been heroes and struggled during the pandemic. On the one hand, that's where we've all looked for care for patients who have been sick with COVID. It's where we're seeing lots of the vaccinations done, a great deal of the testing. Hospital businesses, though, are predominantly fee-for-service. And so as telemedicine has grown, they've been worried about losing revenue from testing that they may have done at their hospitals and just from the higher complexity examinations that they can do when patients are in person. And so it's going to be important to think through how to create incentives for hospitals to want to be involved in sort of value-based payment models, because these are the ones that are most conducive to combining in virtual care. Today, about 90% of care done by hospitals is in fee-for-service, although there's some traction around pay-for-performance programs and shared savings models. And I think you'll see lots of enthusiasm by the Biden administration to create more models that help hospitals move in and health systems move into value-based care and virtual care. This year, we've begun to see more M&A activity across the sector. This is driven by real growth in demand and the success of public companies. And so a lot of private companies are now trying to get larger so they can go access the public markets and lower cost of capital to grow. Recently, there was a merger announced between Grand Rounds and Doctor On Demand, one of the largest telemedicine and navigation companies. MD Live, which was one of the largest telemedicine companies, recently was acquired by Cigna. And so we're seeing a lot more activity. I think that will probably continue. And as I think about the Biden administration, I think that it helps kind of anchor investors as sort of stability around what will happen in the future. First, the ACA is here to stay. We saw in the COVID relief bill augmentation to the subsidies. Biden announced large investments in marketing to help people become aware of the largest subsidies. That actually began today, the largest subsidies. We're seeing enormous investments in COVID-19 response and public health and right now vaccination and testing. But I think going forward, much better IT systems for the country so we can better monitor what's happening and track variants and sequence them much more rapid. Medicaid is continuing to expand, Wyoming most recently. I think we'll see more states continue to expand. And women's health is getting more funding and growing. And I think we'll see more models like Maven really innovate in that area. We've talked a lot about value-based care, Medicare Advantage, and telemedicine. I think that we'll continue to see decades worth of creativity applied there. There's some headwinds. If you were involved in sort of skinny health plans or short-term plans, those I think will have more scrutiny from regulatory perspectives. I think health systems are going to be complicated places as they figure out what is the payment model they want to work in. And then things like digital signing up for insurance, e-brokers will certainly be a growth area too. As I think about implications for employers, health plans, and people thinking about healthcare, I think one, with the capital flowing into Tele-everything companies, they're here to stay. They're not going to go away. They have time to really innovate on their products. You'll see many grow into large businesses. I think it's likely a good strategy to either work with them or emulate them. And also because of the capital, you actually have chances to create companies around areas where you wish there were one. And so you can be an early customer and that can galvanize the company being created. And that's one way to bring innovation into businesses. I think there'll be lots of tension on hospitals because a lot of the savings that comes from better care and virtual care comes at the expense of hospitals that would have historically taken care of those patients. And so that's going to be rate limiting and angsty about how we grapple with that. Most of the startups, one of the things they brag about is that they deliver much better user experiences, high net promoter scores. I think that's great for patients, and I think that will really put pressure on everybody else to replicate some of the innovations that they have in user engagement and satisfaction. And the last thing that's probably the most important is that as more capital flows in and more success is created, we have more talent that comes in. And one of the neat things about my job is that most days I get an email or two from somebody working in a tech company that says, I want to do something more mission oriented. I want to come work in healthcare. And it looks like a much more attractive space now to work because there's more capital availability, more demand for the services, better adoption. And as more talent comes, I think we'll get a lot more imagination and creativity and hopefully adapt a lot of the best consumer products to work in healthcare in a really effective way. With that, I'm going to pause and stop and say thank you, and I look forward to answering your questions as we go. Thank you, Sarah.
Thank you so much, Dr. Kocher. Our next panelist is Dr. Rahul Rajkumar, currently Chief Operating Officer at Optum. Dr. Rajkumar previously served as Chief Medical Officer of Blue Cross North Carolina and Care First Blue Cross Blue Shield. And before joining Care First, Dr. Rajkumar served for 4 years as Deputy Director of the Center for Medicare and Medicaid Innovation. In this role, he led many federal efforts to promote value-based payments for physicians and hospitals. He oversaw programs promoting primary care, the initial federal pilots for the accountable care organizations, bundled payments for healthcare procedures, and patient safety initiatives. Long story short, there are few people who are better positioned to be talking about value-based care. Dr. Rajkumar, thank you for joining us. I'll turn it over to you.
Thank you, Dr. Hallberg. Really excited to be here with all of you. And I'll just say I'm also especially excited and just a little bit nervous to speak after Dr. Kocher, who has been both a friend and a mentor for more than a decade. And so very few times in your life you get to speak right after one of your mentors. So I framed this talk today as fixing 4 medium-sized problems in value-based care. And it's a little bit of a funny wording. Let me tell you what I mean by a medium-sized problem. A small problem is a problem that someone in a position of power should just fix. We shouldn't talk about them on webinars like this. And these are technical problems where most people agree. Big problems are once-in-a-decade problems, like ACA, which Dr. Kocher was an architect of. A medium-sized problem is something that requires a sustained effort by an organization a year, and we should be able to fix 2 or 3 of them in the span of a good year with great leadership. And in the space of value-based care, I'm just going to highlight 4 of these. And so these are things that I think need to happen and will help move the ball where we're all trying to go. So what are we trying to accomplish? Because this is sponsored by Virta, I thought I would just share a little story. I'm an internist by training. I have probably treated thousands of people with diabetes in my career and continue to treat them. I'm not an endocrinologist, but I personally have achieved reversal in exactly 1 patient. And that 1 patient was my father. And the reason for that was that we were able, both myself, my sister, my whole family, were able to spend an enormous amount of time with him on intensive lifestyle and dietary modification and exercise. And it was you could say it was a Virta-like program. And when I try to unpack that experience, what do I learn from it? Every incremental unit of my time has almost infinite value because it's my father. I spent the last decade of my career trying to recreate the magic of that type of experience. I've worked mostly in payer organizations. And so you could think of me as a bean counter or a financial engineer that's trying to make that magic happen by shaping provider incentives. And I would say that over the last decade, we've seen tremendous innovation in the Medicare Advantage space, trying to push it forward in the Medicare fee-for-service space. And the main and most successful vehicle we've had is accountable care organizations in the fee-for-service space. In the early years of the Medicare ACO programs, we saw pretty significant year-on-year growth. That growth has stalled in the last 2 years. So the application cycles have new entrants every July. And this growth is pretty much stalled. And so it's important to examine why. So if you go back in time, in 2015, Congress passed a law called MACRA that fixed the annual physician fee schedule payment gaps and tried to create a 2-tier structure where doctors, physicians who are in advanced alternative payment models, like risk-bearing ACOs, get a bonus. And after the year 2025, their fee schedules grow at a faster rate. And physicians who elected not to be an advanced APM will get no bonus or will get a slower rate of growth after the year 2025. And they can participate in an alternative program called MIPS. Basically, Congress tried to create a gradient between being in an ACO and electing not to be in an ACO and make the alternative to being in an ACO as unappealing as possible. The problem is probably didn't go far enough. And so here are some numbers. These were put together by my friend and colleague, Tim Groninger. So all credit goes to him. But this is a typical 10-doc practice. And so just as a thought experiment, imagine you have a 10-doctor practice looking at their revenues projected for the years 2021 through 2025. And they have high MIPS performance. So they're in Medicare fee-for-service, not in an ACO. And they're high performers. They would earn about $4.6 million from the their billings to the Medicare program. And if they elected to be in an ACO, just their fee-for-service billings would be call it 4.5 million. So there's just on the fee schedule part, they're taking a slight loss relative to the counterfactual, but then they're in an ACO, right? So they have a chance to earn more money. With average performance, potential gains are about $645,000. With call it extraordinary performance, about $1.2 million a gain, which is fine. I mean, that's a substantial amount of money until you get to the last line here, which is what's the potential downside if they're in a risk-bearing track, which is basically required over time. Maximum possible exposure is close to $3 million. And so this makes it really challenging for a small practice looking at this pathway to choose the preferred risk-bearing pathway over staying in the MIPS program. And so the gradient here is not steep enough. So that's problem number one. Problem number two, it is really hard in healthcare finance to fund interventions that have a multi-year return in savings and health outcomes. And, Virta, a virtually delivered ketogenic diet, is a wonderful example of this. So in my prior role, I, as the chief medical officer at two different Blue Cross plans, contracted with Virta. And, I can tell you that Virta requires an upfront investment for a multi-year return. And so the math over 1 year is punishing if you are a payer. You can make it work, but it's not as easy. If you have a 5-year window, no problem. And so one of the variables that introduces is if you're a health plan in MA and ACA and any commercial segment is, can you hang on to that member? And the more churn there is in the membership, the more it erodes the return on the investment that you're making. Now, obviously, we're talking about health. We want to do this. We want to drive as many patients as possible, members as possible to interventions like this. But there is an underlying financial calculation here too. Possible policy solutions are multi-year enrollment in MA plans, in ACA plans. A little more out there idea as a plan, could you access some other funding stream, like a health impact bond that's basically floated by the government? One could imagine doing this under CMMI authority. But the problem is just the fact that plans deal with churn, and churn erodes long-term investments, that accrue over multiple years. Problem three, so many decisions in healthcare are made by plan administrators, many of whom are probably on this call, that are VPs or senior vice presidents of human resources at large companies or small companies. And, there's no value judgment in that for me, except that it really fractures decision-making. So if you are a plan and, any plan, pick any plan in the United States, whether it's UnitedHealthcare or Blue Cross of North Carolina, is actually a coalition of multiple different payment sources. And so if you want to change a policy, like flipping on parity payment for telemedicine, or introducing a new benefit like Virta, Omada, Venrock, anyone, basically, you have authority to do that for your fully insured lines. For your self-insured lines, you often will need to take this to your accounts and basically go door to door in order to make it happen. And that, one could argue that's a great thing. It requires input from a lot of people, and often programs get better when you seek counsel from other people, but it does make it harder. And so these programs are not easy to implement when decision-making is that fractured. Problem number four is that, and I think Bob alluded to this, the next frontier for value-based care is specialty care. Done over the last decade, though we've dabbled in bundled payments, most of what we've done has been centered around the idea that the primary care provider is the quarterback. They are the risk-bearing entity. They are, when you submit an attribution list to CMS, it's basically who is the primary care provider. In most commercial and MA risk contracts, it's primary care focused. To unlock the potential of specialty care and bringing them into the value-based framework, we're going to have to solve lots of micro problems. And so one is attribution. So who is the quarterback? Who is responsible for this patient's care? If you introduce a specialist into the equation, how do you adjudicate who's responsible for the clinical outcome? And how do you divide up the shared savings pie? Who's responsible for the losses or savings that were generated? And then the third one is, to be very crass about it, specialists make a lot of money in fee-for-service. So how do you make the base case unappealing and unappealing enough that you can drive specialists into the value-based framework? So this is the next frontier for payers, is bringing specialists into the value-based framework. Let me pause there. I will turn it back over to Dr. Hallberg and just conclude by saying, we're 10 years into this national journey in moving our payment system into value. We've accomplished a lot. I would say we're a third of the way there. And there are imminently solvable problems that we can take on in the next 2 years that will help get us much, much further down this road and make the magic happen in our delivery system. Thank you for having me here today.
Thank you so much, Dr. Rajkumar. Our last panelist is Dr. Robert Ratner, who is currently the Chief Medical Officer of Virta Health. Dr. Ratner is also a professor of medicine at Georgetown University Medical School in Washington, D.C. After 35 years of active patient care and clinical research in diabetes, he served for 5 years as the Chief Scientific and Medical Officer of the American Diabetes Association. Thank you again for being here, Dr. Ratner. Over to you.
Thank you, Dr. Hallberg. It's a pleasure to be with you. I'm going to shift gears a bit and talk about a specific problem that is incredibly expensive to American society. Diabetes currently accounts for over $400 billion a year in healthcare expenses and societal expenses. It's why I entitled this presentation, The Imperative to Prevent Diabetes. In the early 1990s, I had the great pleasure and good fortune to serve on the planning committee and the steering committee for an NIH study called the Diabetes Prevention Program. The 2 questions were raised by that program. Number 1, can we identify individuals at high risk for developing diabetes? And then number 2, can we intervene to prevent the progression? And many of you may be familiar with these data that were published in the New England Journal in 2001. What the DPP was able to demonstrate was that we could identify high-risk individuals. The placebo group seen here developing diabetes at a rate of 11% per year. And that 2 interventions that we initiated, metformin and an intensive lifestyle, had a significant impact on the ability to delay or prevent diabetes. Now, the study was ended by our Data Safety Monitoring Board after an average of just under 3 years of exposure. But the NIH continued the study. And in fact, though we had to unblind and treat our placebo group, what you can see is that over a 15-year period of time, the interventions continue to have a benefit. These publications came out in around 2010, and from a public health standpoint, people started to think about how do we implement this in a community-based intervention. And one of the questions that came up was whether or not taking this continuous variable of glucose and instead of simply preventing progression, what's the impact of actually seeing regression to normal? Well, that was also analyzed in our studies. And what you can see here is that regardless of the intervention, if individuals within the diabetes prevention program were able to normalize their glucose for any length of time, there was a 56% reduction in the ultimate development of diabetes. So any improvement clearly makes a big difference. So how does all of this get translated into community-based care? That was initiated by colleagues of mine, Ron Ackerman and David Marrero, in the DEPLOY study through the YMCAs. Now, this ultimately became part of the Centers for Medicare and Medicaid Innovation Program. But what they wanted to do was to simply see if a community-based program could, in fact, perform what the diabetes prevention program did, and would it help? And in fact, in their controlled study, it showed a remarkable benefit. This ultimately resulted in CMS agreeing to pay for diabetes prevention when it's being done within a CDC-approved program. And so that was expanded throughout the country on a very rapid basis. The problem with this is that it didn't work very well. So the publications have been coming out over the last year or so where retention in the National Diabetes Prevention Program is only about a third at 10 months. They don't even make it out to a year. The retention is entirely based on the success of the weight loss. The problem is that weight loss is less than 5%, and the goal is greater than 5%. And so, in fact, people have been looking for alternative means of trying to achieve diabetes prevention. Virta started with a clinical trial at Indiana University under the direction of our moderator, Dr. Hallberg, and it included individuals with prediabetes. Now, the Virta intervention is continuous remote care with institution of a well-formulated ketogenic diet. The goal is to lower glucose and get rid of medications. The beneficial side effect is weight loss. We also are a data-driven company. So all of our results are peer-reviewed and published. And this is the publication, and we can make it available to any of you who wish it, looking specifically at the individuals with prediabetes who came into our study. Now, there are several differences between our study and the National Diabetes Prevention Program. First, with the NDPP, you have to go into the YMCA for care. Ours is entirely virtual. Second, we retain people. We had a 75% retention rate at 2 years as compared to their 32% retention rate at 10 months. But in fact, the most important issue here is what impact do we have on reducing progression to diabetes? Now, what I've done with this slide is to give some perspective in terms of our impact as compared to what the NIH was actually able to do. And what you can see is that lifestyle in the NIH program had an 8% progression to diabetes over a 2-year period of time. If you were on metformin in the study, it was a 15% progression. And the control group, as I mentioned before, is 11% per year. They progressed at a rate of 22%. Our population had a 3% progression to the development of diabetes. Much of this was being driven by weight change. So in the top line, what you see is a population distribution of BMI according to class of obesity. And you can see that what we recruited was basically an obese population. Virtually none were normal weight at beginning. Most were class 2 or class 3 obesity. And what you see over time is this progressive leftward shift away from class 2 and class 3 obesity towards overweight and even a couple achieving normality. So that's the beneficial side effect. What we also saw was 46% of our patients actually regressed to normal glucose tolerance. Only 3% progressed to diabetes, 46% actually normalized their glucose. But it's not just the weight that's doing it. It's not just the lower glucose that's important. You can see here that when you put the weight into perspective of the NIH or the National Diabetes Prevention Program, we're accomplishing a whole lot more, and we're doing it virtually. And it's sustained. Are we just treating a number? Are we just treating glucose? The answer to that is no. We're having multiple effects through our intervention on biomarkers of disease. It's not just the insulin resistance and glucose. It's blood pressure, it's lipids, it's liver disease that is all beneficially being impacted by our intervention. And in fact, what we can demonstrate is that with time, we can have a major impact on morbidity and mortality. Now, this study actually came out just recently in the Journal of the American Heart Association. It was 14,000 individuals with prediabetes who were followed for a period of 10 years. That's how many people it takes to get hard outcomes. But what you can see in this middle line are those individuals who remain pre-diabetic throughout the period of time. On the other hand, if you deteriorated from prediabetes to diabetes, you can see that MI, stroke, cardiovascular events, and even all-cause mortality went up. To the contrary, if in fact you regress to normal glucose, there was a substantial and statistically significant decline in MI, stroke, all-cause mortality. The simple fact is that the data are now accumulating that diabetes prevention reduces microvascular complications, it reduces cardiovascular risk factors, it reduces surrogates of atherosclerosis, and now we can even demonstrate a reduction in cardiovascular events and death. From a public health standpoint, it's very clear. We must prevent diabetes. Otherwise, our health systems are going to be consumed by it. That $400 billion a year was from 2017. Clearly, it's much higher now. And with the rise in obesity, it's only going to go up higher. Thank you for your attention, and I'll turn it back to Dr. Hallberg. Perhaps I need to turn back to our moderator.
Yes, I will be jumping in. Thank you so much for everyone's thoughts today, Dr. Kocher, Dr. Rajkumar, and Dr. Ratner. It's a fantastic presentation. We are going to start our Q&A portion today, so if you haven't already, please submit any questions you have for our presenters today by typing them into the Q&A chat box on your webinar console. So we'll get started with the first question today. And it's an interesting one. It's about virtual hospitals. And Anisam was just wondering, what are your thoughts around virtual hospitals and the role they might play in the future? So if any of our presenters today has thoughts on that, would love to hear them now.
Sure. This is Bob Kocher. Thanks for a great question. I think it's a really interesting cutting-edge idea. I don't think hospitals will be virtual. I think you can make the home a place where you can take care of a patient that may have been in a hospital in the past by combining in-person care in the home with skilled nurses, with monitoring by intensive care doctors over video, and people who can track your vital signs over video, or rather over the internet. But I don't think there'll be such thing as a virtual hospital where you take care of yourself in a hospitalized way in the home, because when you're in the hospital, you're terrible. So you can't really take care of yourself. But the home is a place where you can do much more care. And a benefit of home is that patients at home are less likely to get some of the really severe hospital-acquired infections like drug-resistant Staph aureus or VRE. Another benefit of the home is that you sleep better in your own bed, so you're less likely to get delirious, and so the recovery can be a little bit better for people who are at risk of getting more confused if they're in the hospital. And so there's a bunch of benefits of kind of the virtual hospital, and I think we'll see more adoption of that going forward as technology makes it more safe.
Thanks so much, Dr. Kocher. And before I move on, is there anything else that Dr. Rajkumar or Dr. Ratner wanted to add?
I mean, I love what Dr. Kocher said. I would also add that a lot of what was done in hospitals, like if you rewind history and think to the early 80s or 70s before DRGs, is actually now done outside of the hospital or at home. Length of stay has declined dramatically. We've pushed a lot of services into different settings and into the home, and we just don't call it hospitalization at home. We just call it healthcare. Right. And so that will continue. What is really cool is the possibility of doing things that are happening in the hospital right now, like an admission for diuresis or pneumonia, and doing it at home at a higher intensity level. And I think there's just some work to be done for the payment systems to catch up to that, to enable it.
That was a fantastic observation to add. Thank you so much. Our next audience question is sort of around what are the biggest opportunities in healthcare to reduce disparities right now? There's so many things that need to be tackled, but where are you seeing the most opportunities? If anyone wants to weigh in on that question.
I'll go ahead and take a stab at that. When you begin to look at the disparities, much of it is surrounding the social determinants of health. It's whether or not individuals can have local access to health care, whether or not they can get the time to go to that health care, and whether or not they live in a food desert and can actually have reasonable food choices or exercise choices in the environment. I think that's one of the major advantages of virtual care. Everybody's carrying their doctor's office around on their smartphone. And amazingly enough, smartphones are almost ubiquitous, even in underserved populations. So that you're getting to the point now where we can bring the healthcare to the patient as opposed to expecting the patient to come to the healthcare system. They don't have to miss work. They don't have to take public transportation. They can do it from the comfort of their home. And if you have an asynchronous virtual care delivery, then they can do it any time of the day or night that they wish.
Fantastic observation. And Dr. Kocher or Dr. Rajkumar, anything to add on to that you are seeing, any observations?
One additional benefit of virtual care is that it can really expand the choice of providers that a patient may have. And so you can better match on things like ethnicity or gender or even some specialization. And a lot of the areas where we have great outcome disparities is in part because we have much smaller networks of doctors who are available. And so I think that's one important feature. Another one that we've learned from COVID is we need to have better public health. And so I hope that, we make big investments to create, ongoing access in these communities. The efforts to do testing and vaccinations in underserved areas, I think should be continued and converted into primary care. Because that's one of the big differences in the areas where we have less good outcomes is there's less primary care.
Yeah, absolutely. It's a fantastic question and could have an entire discussion based off that for the next hour. I'm going to move on to the next audience question, and it might be best suited for Dr. Ratner, but anyone can weigh in here. Someone's wondering, does Virta offer a direct-to-consumer model, or is it only available through employers and enterprises?
That's an easy question. It is available to direct-to-consumer purchase.
All right, thanks so much for that question. And please, audience members, it's been a really engaging conversation, so please keep submitting questions, and we'll get to those before the end of our time. We have another Virta-specific question. Someone's wondering, is the patient mix representative of all people experiencing diabetes? Are those impacted by social determinants of health being included in these studies as well?
So the answer is yes. The published work from our controlled clinical trial was done in Indiana, so that was somewhat circumscribed. But in fact, our current registry encompasses patients from all 50 states. The spread in age is from 18 up to 79. The ethnicity is across all ethnic groups, including very specific groups of American Indian tribes who have contracted with us. We currently have a program going on with federally qualified health centers, so we're looking at the Medicaid and the uninsured population as well. What we've been able to do is to customize the intervention to meet the needs of the individual, so that if you go onto our website, you'll see very specific nutritional recommendations for vegans and vegetarians. You'll see very specific recommendations for those who tend to follow an Asian or Pacific Islander diet. And what we've just recently developed in conjunction with Blue Cross Blue Shield of North Carolina is a Southern cuisine eating pattern in order to really optimize the intervention on a one-to-one basis and encourage adherence.
Absolutely, personalize the programs to those people who need them the most. It's excellent. Thank you so much for that clarification. This question, I think Dr. Kocher would probably be best suited to answer, but anyone can weigh in. An audience member is wondering about the impact of startups on hospital margins.
I think hospitals are concerned that many of the startups that are out there are trying to build alternatives to care that they have delivered. And so I think there's some tension in terms of how they're viewing the startup ecosystem. Virtual care has many benefits, but it has lower revenue per visit than most doctor's office visits, and things like the alternative payment models that Dr. Rajkumar talked about. A lot of the savings come from patients that thankfully don't have complications and therefore don't go to the hospital. And so I think hospitals are concerned that these innovations could erode their margins, and therefore in some cases are resistant to them, which is why Dr. Rajkumar's discussion about how do you create the right combination of incentives, maybe it's frozen carrots and sticks to get hospitals and the rest of the healthcare system to become more productive is a really important question. And a lot of the country, this is a theoretical conversation because the startups that we're talking about are still small relative to hospitals. But I think in the future, you're going to see real tension and pressure on hospital margins. And there's areas where hospitals have very high margins that are probably going to be attacked by startups. One area is outpatient infusions, where hospital pharmacies, sell the drugs that patients get, and those drugs are sold at very high markups. And so you could see, efforts to go after that if you're a startup, because startups are always looking for arbitrages where they can, see something that's inefficient and make it more efficient.
Yeah, it's a really interesting question to think about. And, in addition to that tension that you talked about, Dr. Kocher, Dr. Rajkumar, or Dr. Ratner, are there any other things that you think hospitals maybe should be looking at as startups become more prevalent?
Yeah, it's a really important question. I mean, so one is just tactically, and in fact, we see this happening in parts of the country, is hospitals trying to play in this space. So either forming, provider-sponsored MA plans, making more deep investments in delivery. And so I think they're following where the market is going. The only other comment I'd add is that I have some belief about the end game for all this, which is that in a future world, you could imagine hospitals being global budgeted, and the experimental ground for that is Maryland, which has a hospital global budget program under CMMI authority, and then rural hospitals in Pennsylvania under the CMMI Rural Hospital Global Budget Demonstration. So, effectively hospitals have a fixed budget. It gives them some long-term security for planning purposes, and they just become a cost center for a healthcare dollar that's managed by the primary care provider.
Yeah, some very interesting examples. Thank you both for weighing in on that question there, and thank you, audience, for fantastic questions. Please keep submitting any questions that are coming to mind. We'll make sure to get to those. Our next question is about, telemedicine, and really we've talked a lot about that area today, but if you had to, pick the next opportunity, what's the biggest one that you see? What would it be?
This is Bob. I think specialty care probably is the most interesting area. We're seeing specialty care like what Virta does for complex diabetes. We see it in mental health, but I think there's a whole bunch of other areas. You can imagine a lot of cardiovascular care can be done virtually. Orthopedic surgery and musculoskeletal, there's more things you could do there. Patients with rheumatologic diseases, you could see how they could get much better care with more close monitoring. So I think it's specialty care.
I agree. So that would be number one on my list. Number two would be trying to rebuild or replicate the primary care model for different populations, like Medicaid. Much of what we see in the market, like Oak Street Health, Iora, ChenMed, are MA-based models. And can you replicate this model of beautiful, intensive primary care within a different payment system?
I want to expand on Bob Kocher's comment. I think that chronic disease is the direction that telehealth has to go in, both because it's now the most common problem that we have in the United States and the most costly problems that we have, and because chronic disease requires patient involvement. Ultimately, the person with the chronic disease is their own primary care provider. And what virtual healthcare and continuous remote care can do is to provide that patient with the guidance for their own self-care, whether it's asthma or diabetes or hypertension or cardiovascular disease or musculoskeletal or mental health. What you're doing is you're intervening to help the patient live their own life. And a brick and mortar environment simply can't do that with 2 to 4 visits per year. It's the interval between that's so critical.
Yes, thank you for that add-on, Dr. Ratner, and thank you all for your observations there. It's really helpful to hear from everyone and their thoughts on that. This next question, I think, is probably best suited for Dr. Rajkumar. It's on value-based care models, and someone's wondering, for those value-based care models, what are some of the pathways to a more comprehensive approach to integrating more providers into value-based models and away from fee-for-service arrangements?
Yeah, I mean, if you look at the startup world, most of this, as I said, most of the successful models that are in the market now are almost exclusively MA focused. And so they have panels that are, it's filled with MA and usually 2 to 3 plans in a particular geography. For this to work for the rest of the country, you need to create value-based models that include the payer mix of a typical primary care provider. Right? And so let's start with primary care. And that means in the place where you live, there's a pathway for the Medicare fee-for-service population that you serve. Your commercial plans, it's often like a dominant Blue Cross plan, needs to be offer a risk-based program, and then a Medicaid offering. And I think another critical thing would be that the programs are roughly aligned. So there's agreement on what is quality of care, how we're measuring quality, so we're not driving the providers crazy with multiple or conflicting measures, that it's as parsimonious as possible, and that the basic mechanics of the programs are roughly similar. And so one of the problems right now is that you may have an MA model that heavily rewards risk coding, or a particular set of STARS measures. You may have a commercial program that has different pathway to success and different quality measures and then different levers. And that creates the conflict. And then, as I said in my talk, I just think making the alternative as unappealing as possible, which is not the way that public officials speak, but as a private citizen, I can say this. That's a really important part of this. So when I was in my prior role at Blue Cross North Carolina, our policy was that fee schedules are flat across the network until you enter an ACO agreement. So until you take accountability for total cost of care and quality, rate increases are 0. And it takes that level of conviction to move the payment systems. And I think the zone in which I have the greatest concern right now is specialty care, just because the alternative to being in the value framework is so appealing. It's whatever the opposite of unappealing is. It is so lucrative for most specialists that it's just incredibly difficult to conceive of a different financial construct that would be appealing to a specialist right now.
And as a follow-up question to that, do you have any ideas of how to make those base case rates more appealing?
So in the commercial world, you have some control over it. It's whatever you can negotiate and still field a network. At the CMS level, I think it just requires a concerted push from whoever is in those chairs and potentially. Potentially action at the congressional level, but it has always been one of the really difficult things to do for federal policymakers for obvious reasons. I mean, there are many people whose interests are aligned with schedule being the way that it is. I mean, one other thought would be to test it in some limited part of the country using CMMI authority, which is a way of taking a baby step into this, and it might make it easier to do in the long term.
Yeah, the transition from fee for service to value-based is complex, and I really appreciate you breaking down those 2 questions and providing your insight, Dr. Rajkumar. Thank you. We do have time for one more question. This one will be for Dr. Ratner. Someone's wondering, do you envision that the PP program is going to gain any traction going forward, or are these program models kind of behind the times?
I'm sure there will be more innovation in terms of applying the CDC type programs. Clearly, the observations in over 30,000 individuals who participated in it have not been successful. There was an editorial in the December issue of Diabetes Care that actually challenged the scientific community to come up with alternative models for diabetes prevention. I think that Virta is one of those potential alternative models. There are others out there, and I think that it's incumbent upon all of us involved in diabetes prevention to collect our data, to present our data at scientific sessions, and to have it peer reviewed so everybody can see and assess its value.
Great. Thank you so much, Dr. Ratner, for your observations there. And thanks so much for the audience. It's been a really engaging and thoughtful conversation today. So really appreciate you taking some time to send your questions over to us. And a final thank you to Dr. Kocher, Dr. Rajkumar, Dr. Ratner, just for all of their discussion and thoughts today, and also Virta for sponsoring today's webinar. So to learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you so much for joining us today, and we hope you have a wonderful afternoon.
Thank you.
Thank you.